coordinator. So it's my pleasure today to introduce Dr. Bonnie McCann. Dr. McCann is an associate professor and medical director of pediatric endocrinology at Texas Children's, the Woodlands campus. She completed pediatric residency and endocrine fellowship at Texas Children's and is currently the co-lead for diabetes community care process team with a special interest in increasing community awareness, support, and engagement in diabetes care. I'm going to turn the podium over to Dr. McCann now.
It's my pleasure to be here today and to talk about some of the projects that we've been working on at Texas Children's in community engagement in diabetes care. Okay, so today, just a brief overview. We're going to review data on community engagement in diabetes care, identify potential barriers and areas of need, and then discuss ways that the endocrine team can intervene and provide diabetes care in the community. So I always like to show this slide just to highlight where patients spend their time. And so you can see this teeny tiny little area, this little sliver in blue, which is the amount of time that patients are actually spending with us, their medical team. And so what areas are things that we can target? So they spend a lot of time in home, in the community, and then this small segment here in yellow, which is school. And so we know that there's a lot of factors that play into health, such as social economic factors, their physical environment, their support structure. And so those are different areas that when we think about diabetes care are super important. And so what do we actually know about diabetes engagement in the community from studies and literature? So we obviously know that this starts before diagnosis, and recognition of signs and symptoms by the primary care providers is critical. And what we've seen is that in previous studies, about 20% of children presenting to primary care are not diagnosed at the first clinical encounter. So they may show up to their clinic, their PCP on a Friday, get some labs done for signs and symptoms, and then it's beginning of next week when they actually get results, and there could be a delay in diagnosis, which leads to increased risk of DKA at presentation. And so when we think about what different areas we can actually target, primary care provider education is a key part of this. And then of course, schools, which is a huge part of where children spend their day. And we know that appropriate care in school is necessary for safety, long-term well-being, and their academic performance. And school nurses are very well positioned to actually provide intensive care for students with diabetes, but only if they're appropriately trained. And so a lot of previous studies have shown that the majority of school staff members have an inadequate understanding of diabetes and may not feel comfortable with recognizing signs and symptoms. And there's a lot of factors that play into this, and such as school nurse training and skill level, their experience, if they've had students with diabetes in their care before, school staff and teachers' awareness and knowledge, and then school district, local, and state policies, so from the top down. Barriers, there's a lot, but lack of appropriate training. So school nurses have a lot of time constraints, they're busy, they have a lot of other students that they're caring for with different chronic medical issues. There's also difficulties in initiating and continuing programs for diabetes management, lack of experience and knowledge, which we touched on, lack of appropriate communication, not only between school nurses and families, but also school nurses and the medical team, and unavailability of nutritious foods and snacks, lack of support for extracurricular activities, so coaches, other non-nurse personnel that may not feel appropriately trained or understand the complexities of diabetes. And I like this as a busy slide, but I do like that this kind of highlights all the interacting factors when it comes to school diabetes care. So obviously you have the student in the middle, and you have to make sure that the nurses are appropriately trained to give the insulin, to understand treatment of hyper and hypoglycemia. We have the teachers and other school personnel that are important for their physical activity, their dietary intervention, and then of course the local hospitals and healthcare providers that are providing training and resources to the school nurses, updating school orders. Cooperation of the parents is another big factor with school nurses, with teachers and other school personnel, and then peer support from classmates. And so a lot of different areas when you think about, what could improve care when children are actually at school. In terms of social and community support, we know that social support is a protective factor across the lifespan. It's correlated with more positive psychosocial and diabetes clinical outcomes. And there's limited data, but the data that we do have shows that that adolescents with type 1 who participate in these support groups have significantly less perceived diabetes burnout and more knowledge of their disease. Diabetes camps is another way for community support to occur. So it can be an equalizer. It's a place where, kids, understand diabetes. Everyone there is kind of on the same level, and they understand the complexities of it. Most data suggest at least positive short-term outcomes from camp in terms of just their comfort level with giving insulin shots and things like that, and their understanding of diabetes. But there's just not a lot of data on long-term psychological or medical educational outcomes. And part of that is because camp is, designed, it's supposed to be fun, right? It's not supposed to be like a research lab. So we don't have a lot of long-term data on those outcomes. And then when we think about other ways that we can target, advocacy is a huge one. So insulin access and affordability, access to technology, so pumps, CGMs, and then obviously safe and appropriate diabetes care at school. So when we think about these different aspects of where patients are actually spending most of their time, what areas of diabetes care can we actually impact? And so when I thought about this, I broke it down into 4 main categories. So education, this is education for primary care providers, education for school nurses, education for families, communication between healthcare team and school nurses, advocacy, which we talked about for insulin affordability, technology access, and then support and empowerment initiatives as well. And so when we thought about all of these barriers and areas of need, Texas Children's, the endocrine department, created what's called the Diabetes Care Process Team. And this was created back in 2013. So we're coming up on 10 years of this team being in place. And essentially what this team is, it's a multidisciplinary quality improvement team. And there are 5 main sub teams essentially. So there's an inpatient team, high risk team, clinic team, education team, and then the team that I co-lead, which is the community diabetes care process team. And so all of these teams are focusing on different aims and initiatives to improve care in different avenues. And so our team, the community diabetes care process team, again, is a multidisciplinary quality team. It's led by myself and one of our clinical nutrition managers who manages CDCESs and RDs as well. We have multiple members on this team, which includes MDs, nurse practitioners, CDC, ES, RN, social work, and we've also had parent advocates as part of our team as well. And we follow the classic PDSA cycles. So it's a quality improvement team. And so all of the aims that we do and what we'll talk about on the subsequent slides will show you are these different PDSA cycles that we go through to see if our intervention actually makes a difference and how we track that data. And so we're gonna take you on a journey of the last almost 10 years of our team, what initiatives that we've actually done and implemented. And we're gonna go first with the education initiative. So highlighting school nurse and PCP diabetes education, and then patient and family education. So we started off pretty early on through 2016 to 2018 and created basically CME accredited lectures on diabetes management for the primary care physician. And we had about 8 of these lectures. Some of them were in person, some of them were kind of video, Skype, lunch and learns, virtual visits, virtual meetings. And what we did to track knowledge was that we had a pre and post test assessment and basically had some questions that they filled out before the activity and after the activity to assess their knowledge in managing or recognizing signs and symptoms of diabetes. And so you can see we had 75% for our baseline assessment and 94% for our post assessment. And so there's definitely an improvement in knowledge there. And I think part of this was also helpful just to get the communication between our team and the PCPs in the area, because we went throughout the whole Houston area, a wide range, private practice, Texas Children's Hospital, pediatric groups. So we tried to target, the whole region. And people were aware of who we were. They were able to contact us easier. And so I think in terms of just communication with our team, it just kind of broke down some of those barriers. And then a big initiative that we've been working on is school nurse diabetes education. And so since 2018, we've had an annual all-day CNE school nurse diabetes management conference. So we actually had our 5th one yesterday. So it's been a very busy weekend for me. But we have different topics every year. So we talk to the nurses about just what is type 1, what is type 2, what's the difference, updates on diabetes technology, help with carb counting, insulin dose calculations, management of emergencies, hypo or hyperglycemia. And every year it looks a little bit different, but we do get feedback, evaluations from the school nurses, and that way we're able to kind of target the next year's conference and see what the areas of need are. And the topics are given by different members of our team. So we'll have like an RD talk about carb counting. We'll have MDs talk about technology. We'll have social workers talk about burnout, and psychologists talk about burnout as well, and just things to recognize for the nurses. And so this is just an example of one of the ways that we track our effectiveness. And so this was from last year's data. And this was basically, we wanted to see a 20% increase in confidence in 5 different key scenarios based on key skills. So we had a pre and a post assessment. Some of these included insulin to carb ratio calculations, management of hyper and hypoglycemia, estimate of carb counting, and then describing the difference between type 1 and type 2. And at least in 4 of these 5 key scenarios, we did see an increase above 20% in their confidence. So just one of the ways that we look at. Another thing that we've been working on is family education. And part of this, there's some overlap because we do have an education care process team that works on these initiatives as well. So there can be some overlap between our different process teams. But family education, we had a student athlete conference a couple of years ago. So just managing type 1 and the student athlete. And this is a snapshot of our agenda. It was kind of cute. They had quarter 1, quarter 2, quarter 3, quarter 4 for the different sections of the talk. But we had different speakers. So Brandon Green is a former NFL player with type 1 diabetes that came to kind of kick off the event and share his experience and how he's managed diabetes on the field. And then we had dietitians, physical therapists, and then a parent advocate as well, just to kind of make sure that for these student athletes, things were updated in their 504 plan and their extracurricular activity plan. And then in terms of communication initiatives, the ones I'll talk about are our diabetes school orders, and then our partnership between school nurses and CDCS. So in terms of the school orders in 2015, our school orders before that were paper. It was very cumbersome. You had to print them and fax them, and it was a lot of unnecessary paperwork. And so we converted all of those school orders from paper to part of our electronic medical record. And it's super easy now. There's a few, you just kind of click through it. Anyone can update it. And then it can be part of their medical record. You can send it to the patients directly through their MyChart, or it can be faxed to the school nurses. And after we did this, we reviewed the orders with the school nurses, just made sure they were comfortable, and we went to kind of their regional school nurse conferences to discuss this. And then every year we have an annual review with key stakeholders. So we have a committee, it's made of MDs, school nurses, parent representatives, and CDCES to kind of review the orders, see if there's any issues, and make adjustments. So one example of that, we had a Dexcom action tool that we created to give the school nurses some guidance based on, what is the blood sugar, what is the arrow on the Dexcom, what do you do in terms of intervention? And obviously that can be tailored patient by patient, but just some general guidelines for them to follow so they felt more comfortable with this new technology as it was emerging. And then in terms of CDCES and school nurse partnerships, one of our newer initiatives was to have increased communication amongst our team for those that have had come in with repeat DKA admissions. And so our aim, and this is kind of an example of the aims that we create and what we look like when we present our aims to our internal group, but our aim was that 75% of all school-age DKA admissions would have an updated school packet sent to the school nurse by June 1st of 2022. And the go live for this was September 2021. And essentially what would happen is these patients would come in, have a repeat DKA admission. We would update the school orders, and we'd have a new kind of what we call smart phrase, which included contact information for the clinic, the update on their recent DKA admission, requirement of the school nurse for close supervision and blood sugar checks and insulin dosing at school, and then a plan to provide us with feedback in the next 2 weeks with blood sugar logs and whatever else we could do. And then there would be communication between our team and the school nurse so we can make adjustments. And if it was, we needed to work with the parents to make sure they were getting the appropriate supplies to the school, like we would help intervene that way. And so this is an example of one of our run charts. So we keep track of all of our data. It's a nice way in real time, you can see what's actually happening. So all of this is pulled from the EMR. And so you can see the blue columns are the number of DKA admissions we've had every month throughout the Texas Children's System. And then the green is the percent of those school orders actually being sent. And you can see we're not quite meeting our goal. We're, more like a 15% average. And part of that has been a lot of turnover with staff and making sure that our process is actually working. So this comes into that PDSA cycle. Where's the breakdown and what do we need to do to actually get our rates up? So this is a newer initiative, but an example of kind of how we track what we're doing and see if it's working, if it's not working, and then what do we do to kind of move forward. I'm going to spend a little bit of time on advocacy initiatives, and the big one that we worked on over the past few years, obviously for those of you that are in Texas, was coverage for CGM from Texas Medicaid and advocating for that. And so we all here in Texas know that before April of 2020, CGM was not a covered benefit for pediatric patients with Texas Medicaid. And I'm going to walk you through a lot of the different cycles that we went through to help advocate for our patients at both a local and a state level. And obviously, we were advocating. It wasn't obviously our team that made this happen, but it was kind of pushing on the state in different ways to try to get this covered. So this is a multi-year journey we'll take you on. So in 2014, we collected our baseline data on CGM rates. At Texas Children's, we had about 8% of our total patients, commercial and Medicaid, that were actually on CGM. So pretty low in 2014. And in 2016 of September, we started looking at this initiative, and we started submitting CGM applications for certain high-risk patients on our local health plan. So Texas Children's has a Texas Children's health plan. It's a Medicaid plan. And so we started submitting a small proportion of patients. So these were young children, less than 5, hypoglycemic events or hypoglycemic unawareness. So we started with that kind of small focus group. And then in November of 2016, we created what's called a Cgm Evidence Summary. So basically we just reviewed the literature. We provided a document that described, the benefits of CGM in terms of health outcomes, what we knew from the literature, and then as well as, potential cost saving data. And then this was created with part of what's called our Evidence-Based Outcome Center. It's a center within Texas Children's, and they kind of help us create these summaries. And then in January of 2017, we had meetings with Dexcom and Medtronic representatives just to hear stories from success in other states that had already gotten approval, and if anything that we could do on our end could help. In March of 2017, we started collecting letters from providers, patients, families on their experience with CGM, things that we could submit to the state to provide, at least testimonials of why they felt like this was helpful for them. And then in December of 2017, Texas Medicaid has what's called a topic nomination form. You can fill out for a covered benefit that you would like to see happen. And so we submitted one on behalf of Texas Children's, and we included our CGM evidence-based summary. And then in September of 2018, we had to follow up with our medical director for our local health plan, because we had at this point submitted maybe 20, 25 applications, and we were getting only a very small proportion actually pushed through. About 5 patients of the 20 that we'd actually submitted actually got CGM. And part of that, we had to kind of revise our billing codes that we submitted, because there were certain codes and certain suppliers that were in network that we could actually work with to get at least a few of these pushed through on a case-by-case basis. They were not approved by Texas Medicaid, but they were CMS allowable. So we had to go with those certain billing codes, certain K codes. And then in October 2019, the Texas Medicaid draft policy for CGM came out. And so on behalf of Texas Children's, we created a response letter to that draft policy, just addressing any issues or concerns that we had, a few things that we would like to see in that policy. But overall, like, we were super excited that this was actually going to happen. And then, of course, as you all in Texas know, in April of 2020, we got great news that Texas Medicaid approved coverage for CGM. So a lot of different factors that we were trying to advocate for our patients in this way. And here's a run chart of our rates. And so you can see our baseline from 2014, we're about 8%. And this, again, this is just looking at total patients, Medicaid and commercial. By fiscal year 2021, we were at about 64%. So definitely a significant improvement there. And on this next slide, I know it's a little small, but wanted to show you our run charts for our commercial and our Medicaid managed care patients. So on the commercial side, as of just, I think last month, we were at about 87% of our patients with commercial insurance on CGM. And then for our Medicare, we are about 60%. So more improvement to go, but a huge jump up from where we were, obviously, with getting support from the state to actually do this. So this is something just to show that a way that we can advocate for our patients, and a way that we can actually try to make things equitable for our kids with type 1. And then I'm going to spend a little bit of time just talking about support and empowerment initiatives, and we'll go through these one by one. So food insecurity screening is another thing that we've really been working on recently, a new pilot that we've started. So in the Montgomery County, and that's kind of the area, so I'm at the Woodlands campus, which is about 35 miles north of the main campus in downtown Houston. And in our surrounding county, 1 in 5 children have identified as food insecure, which is huge. And some of the surrounding counties are even higher. And we know that food insecurity is independently associated with poor glycemic control, increased odds of diabetes-related complications in youth and young adults with type 1. And the ADA guidelines, of course, do recommend screening for food insecurity, as this is a social determinant of health and critical. And so this, again, is an example of our AIM statement. And we aim that 75% of our diabetes patients seen at Texas Children's The Woodlands campus would be screened for food insecurity by May 1st, 2021. This initiative was started in October of 2020. And we began our pilot to screen all of our patients that either had a telemedicine appointment or an in-person clinic visit. And all patients that had a positive screen were provided basically a booklet of social services, local food pantries in the area. So we had to do our research and kind of figure out which food pantries were open in the community and that were available to provide resources. And we also created insulin cost savings resource guide as well. And so this process had multiple iterations. Initially, we started off verbally, like the medical assistant or the nurse would verbally ask the food insecurity questions to the patient as they were getting checked in and roomed. Then realizing that that is probably not the best way to do it, because some families may feel uncomfortable having that conversation in front of their child and may feel embarrassed or just not comfortable at all. So we revamped our process. And now the way that it is done is a paper form. These patients, as they're checking out or checking in and filling out their other paperwork, it's just part of their stack, and they fill it out. And it basically says, okay, if you're food insecure, do you want to have a conversation about this with your healthcare provider, or are you interested in any food saving or food resources? And if they say yes, then we can actually intervene and have a conversation. And so this pilot did expand to our Texas Children's main campus in the medical center in June of 2021. And I'm going to show you that data in the next couple of slides. This is the screening tool that we use, and this is called the Hunger Vital Sign. And it's a 2-question questionnaire. And so the questions are: within the past 12 months, we worried whether our food would run out before we got money to buy more. And the second question is: within the past 12 months, the food we bought just didn't last and we didn't have money to get more. And so if they answer yes to these questions, then they're offered those resources. And we track this in an epic that we have, and the medical assistant puts in these answers, and we're able to track it that way. And so this again is another example of one of our red charts. And you can see from the Woodlands data. So the red bar, is the red line is the percentage of patients that are actually being screened. So if you remember, we wanted a goal of at least 75%. We're not quite hitting that. We were about 66% of our eligible patients that were actually being screened. And so part of this is some staff turnover and just understanding the process and making sure that this data is getting entered appropriately as these patients are checking in. And so that again into that PDSA cycle where we reevaluate the process, see what's working, what's not working, and what do we need to do to improve. But you can see that of those screened, the green line represents the percentage of patients identify as positive, that they do have food insecurity. And for the Woodlands campus, we're averaging about 10%, which is a significant amount of patients. This is medical center data. And if you remember, I told you they started in June of 2021, so there's no data prior to that. But you can see they're hitting closer, they're definitely increasing their rates closer to 50% screened. And of those that are screened, you can see their rates are a little bit higher on average for those that are actually food insecure. So they're hitting about closer to 15%. And so again, a huge area of need, and our ultimate goal, what we want to do is we want to screen them for food insecurity. If they identify as food insecure, we want to provide them a food prescription. And our dream is to have an in-house hospital food pantry where we would send them down with their food prescription. They would be provided a box of fresh food, vegetables, meats, that kind of thing, and then be sent home. And so this is happening in their hospitals. So in Harris County, some of the adult hospitals do actually have a food pharmacy, a food pantry in-house. And what we are planning to do is partnering with our local food pantries in the community to actually supply the food for this initiative and create a partnership there. And so we're working on this. We have space actually at the Woodlands campus where it's estimated that it will ultimately be. Have like a design plan, some legal, just making sure we're good with legal. So there's some steps that we need to actually make sure that this can happen. But this is the ultimate dream of what we want to accomplish. And so I think we've proved that there is a need, and hopefully news to come in the next few years. I mentioned support group earlier on in the talk, and so we felt like this was an important initiative. So we started a diabetes family support group. This has been ongoing monthly since 2017. Prior to starting, we sent surveys to patients and families just asking, okay, what time of day would you actually be able to attend, and what day of the week? And so we got pre-data to kind of figure out what's the best day and time of the week. Turns out it's Thursday at 6 p.m. That's where everyone wants to be. And so we created basically advertisement through their medical records. So every month they're sent out through their MyChart. What's the next month's topic, and they can register, and there's a QR code they can register for the event. We keep track of our attendees. It's also advertised through our Texas Children's Hospital Facebook page and through our local partnership with our JDRF chapter through their venues. And now it is obviously in a virtual format, which I actually think is better because the area that we care for with Texas Children's is huge, right? Houston's a huge area. So I actually think it's a better way to do it, that they can log in wherever they live or wherever they are and not have to drive to a certain location to attend. And so we have different talks every month, and I'm going to show you an example of 2021's curriculum. So we started the year off with a bang. We had a NASA scientist with type 1 that came to talk to our kids about living a resilient life with type 1 diabetes. It was really well attended. They had a lot of fun. The kids asked really cute questions. So we really had a good one with that. And then the rest of the talks can vary, but usually every year we'll include emergency preparedness for hurricane season. We'll talk about back to school and 504 plans. We talk about diabetes burnout. And those talks are really, people cry. It's really, really intense. I think it's important that people feel supported. And so we'll have our psychologists lead those kind of talks. We talk about transition to adult care. We talk about technology troubleshooting. We talk about management and athlete. Usually right before the holidays, we always do our carb counting talk, just for a FYI. It's always a lot of fun, but we really get great feedback from this. And again, we keep track of our participants, and it's been really cool. And then more fun stuff. So we did a couple years ago, actually 2 of these events, a diabetes Halloween party called Diabetes Bash. It was at the Houston Health Museum. You can see pictures of our providers and staff there that are participating and volunteering at the event. But that was super fun. The kids had a great time, and all kinds of snacks and foods and all kinds of things. And hopefully we'll be able to do some of these in-person events in the future. And then we do have a partnership with Diabetes Camp for ADA Camp Rainbow. This is a day camp that I have in the Houston area. It's for children aged 4 to 17. Dr. Gunn, her picture's up here on the right. She's our medical director, and then our providers and staff love to volunteer and be part of this group. And then in terms of with JDRF, we have a strong partnership with our local Houston, actually it's the Southern Texas chapter of JDRF, and they provide our bags of hope for our new onsets, and they help us support our support group. And we also have an annual Texas Children's Endocrine Walk team, in November, JDRF Walk. And that's a picture from our team from this past year. So the summary, so this team, our care process team, uses a multi-pronged approach to allow us to reach patients, families, members of the healthcare team, and the community to improve their knowledge, access to technology, and provide support and resources. We have a lot of future directions. We like to dream big. We want to expand our school nurse conference to, extend not only throughout the region, but throughout Texas and beyond. Actually, yesterday we had about 176 school nurses attend, so we want to get even bigger than that. And I think with the virtual format, we're able to expand. We want to create a video library for specific diabetes family topics, things like the emergency preparedness, things that they can get on demand if they have questions, and not necessarily have to wait till the fall talk. And then we'd love to create a diabetes Spanish support group as well. We haven't really delved into that, but that is a huge area of need what we want to tackle. And then more advocacy for our food pharmacy, pharmacy with the farm. So this is kind of a summary of the journey that we've been on at Texas Children's, and I'm happy to answer any questions and get feedback.
If you'll look, there should be questions you can see on the Q&A.
Yeah.
Sure, go ahead.
Yeah.
One thing, since we don't have a mic, a roving mic.
Just repeat.
We have one. I'll grab it in a second once I get the check for him.
You had mentioned about the school nurse process and having them reach out post DKA.
Yeah.
We kind of ran into that problem in codes where the parent didn't approve direct nurse to office communication. And there were some already issues there. How do you guys deal with that? That problem?
Yeah, so the question was about the communication between the school nurse about the repeat DKA and communicating with us, and some parent pushback and not wanting to actually allow that communication to happen. We have had some of that. I mean, it's not been the majority, obviously, but we do run up on those on a case-by-case basis, and parents have to sign off that it's okay for us to communicate. So it's not like we can just blanket, they have to sign on that school order that it's appropriate for us to communicate. So, if they don't sign it, like, we can't actually have that conversation, which makes it really challenging. So we try, in those situations, to have conversations and explain like why we feel like this is important and how this is going to improve the care of their child and that kind of thing. But at the end of the day, they have to sign off on it. So that can be super challenging. I don't have a good answer for that one. No magic bullet for that one.
Continuous glucose monitors. So I think it's insurance coverage and all that. There is a willingness to wear the sensor.
Yeah.
So what do you need to experience?
So that is a whole nother project that some of our other teams have been working on in terms of actually increasing uptake of that technology and starting to wear it. So we're starting to try, at least from new onset, to try to get these kids on sooner, because we feel like if they're on it from the beginning, it's not as much of a challenge to get them on it later. And we get a lot of reasons they don't want to wear it. They don't want something on their body. They don't want to feel like they're a robot or that people are looking at it. They feel like it's uncomfortable. There's lots of different reasons. Other issues that still come up are the cost of the ongoing supplies, and that's something that is difficult to tackle. So I think you know, I think from us, we're trying to move to getting them on it from the beginning, just to make it, okay, this is how you monitor your blood sugars. And so that's what a new initiative that we've actually been starting over the past year.
Very good talk. A couple of questions. So I think we're probably going to steal from you on school nursing. That sounds great. But I'm running into the barriers with trying to get the back and forth communication with school nurses on like the high-risk patients.
Yes, so there's always barriers with that. And, you know, I think that's part of why we wanted to expand our school nurse conference. And I've gone like to their regional meetings and had like, okay, please, if you have a student that's high risk, please communicate with us. And we always run up into barriers with that. But I think the more that we get out there and our face out there and our name out there and like, okay, we're here for you. We're not, please reach out to us. I think the more receptive they are to actually having those conversations. But it's still a work in progress. And I would say that communication part, that new initiative, it's had several iterations. Initially, we were starting with having our CCES call the school nurse and like going outward that way. And that really wasn't happening. So then we tried to say, okay, let's send out the new school orders, have a request and order for them to respond to us. And so that's kind of where we are now. And we'll see, time will tell if that's actually making a difference for those high-risk patients. Because again, it is kind of a newer initiative, and you can see our rates right now of actually getting those orders out are pretty low. So that's part of the barriers. We actually have to get the orders out so that they can actually communicate with us. So more to come on that.
I agree. And that, say what you will about it. The orders and that really the game changer for us as well. Remind me, we still have our school nurse hotline. Okay, so we have a hotline too for the nurses to call in. It's utilize some of that. That's another option. It's just hard as I'm familiar with all the staff.
Correct.
All responsibilities. Let's see. I had one other question for you about Dexcom or Cgm education. What do you have any resources or any tips as far as helping families and children to use the Dexcom or use Cgm?
Yeah. So that's part of the initiative from our education care process. And they have actually created educational materials for new starts on those technologies. And so I can share that with you. I'm sure they would be very happy to share those documents with you, but we have created kind of our own internal ones to provide to families.